All right, let's look at another question in trying to see how we can analyze a question when they're written for NBME Shelf Exam or USMLE. And these are questions related to clinical neurology, of course, written by some of our students. And I'm going to just analyze them. So here's a question. A 76-year-old right-handed male patient presents to the clinic with his daughter due to recent forgetfulness. So 76-year-old forgetfulness, again, concerns for cognitive impairment. His daughter states that over the past year, he has forgotten to make important payments and will have difficulty recalling certain members of the family. Now, that too is actually a little challenging because forgetting to make important payments is a short-term memory problem that you received a bill in the mail and you thought, okay, let me put it on the table and I will pay it this evening or tomorrow. And you put it on the table and you forgot the next day. While recalling certain members of the family, you're presuming here these members of the family are the ones you have known for years or decades. Not like somebody just showed up yesterday or last week and introduced himself and now you forgot. So you basically are now mixing in a short-term memory loss and a long-term memory loss, which is again a big no-no. There are diseases that can do it, but that is not typically what we teach the students, which those disorders that mix in the short-term and a long-term memory loss. So here, difficulty recalling certain members of the family, I will for now take it as a confusion, not a memory loss. So now in my mind, I'm thinking, okay, this patient has a short-term memory loss and some episodes of confusion where he's not sure who the next guy is. And this disorientation now make me think about those dementias that cause confusion. And if you have seen my video on the last question, then we just talked about Lewy body dementia, which classically does it. Lewy body dementia creates these episodes of confusion. The fluctuates go in and out, and that's what can cause difficulty recognizing certain members of the family, not because they have a loss of the memory. He gets so frustrated when I point his memory out to him, which is classical for lack of insight. And that is again more common in certain dementias or others. For example, classically in Alzheimer's disease, early on, patient has no insight. They do not recognize that they are forgetting things. And even when they're pointed out to them, they say, no, you're making it up. I don't have very much of a problem. And that is also very classic. Um, Sometimes he will certainly remember something and be like his old self. Now, that is again very challenging. Now, again, that is very suggestive of confusion that sometimes he's very good and sometimes he's not that good. And that is the fluctuating cognition that, again, you will ascertain more with Lewy body disease rather than Alzheimer's. But then the short term memory loss, forgetting to make payments, is an Alzheimer's disease feature and not a Lewy body disease feature because in Lewy body disease, you typically have relatively intact memory. And problem is not the memory, but the confusion and hallucinations and things like that. On exam, he has grossly intact reflexes and motor strength. His Montreal Cognitive Assessment score is 22 out of 30, which is, pretty common in someone who's having cognitive impairment. Sometimes we divide them into MCI, mild cognitive impairment, and dementia. So 22 will be more of in a dementia range. So between 23 to 26 will be a mild cognitive impairment range. But these kind of numbers are better studied on MMSE, more mini mental status examination from Polstein. In Montreal, cognitive scores, the data is unclear, but 22 is typically considered a score where you're hitting dementia or just below 22. So he may be a borderline. What is the most likely diagnosis? So see, there have been too many curveballs here to try to say, okay, what is the actual scenario here? Now, this might be an actual real life scenario, but in real life scenarios, you now have opportunity to examine patients again, have a follow-up visit, do some blood test, or have them do some more scales, send them to psychology, do an MRI of the brain. But in a STEM or in an MCQ, you don't have that option. So that's why we prefer never to put in any confusing information in a STEM because the reader is doesn't have the opportunity to go back to the patient and ask questions. So that's why he's only bound to information you're giving to that patient and to that student. So let's look at the option. Dementia with Lewy bodies, as I mentioned, the only thing so far striking here is the concern for episodic confusion. Otherwise, there is no Parkinsonism, there is no hallucinations, or two of the important three triad of Lewy body disease is missing. Major depressive disorder is possible, especially because the author is saying that sometimes he's very lucid, which will be unusual. for permanent dementias, like Alzheimer's disease. Major depressive disorder can impact you so much that you look like you have dementia. So forgetting to pay the bill can be a symptom of a depression, just like forgetting to eat or forgetting to change your clothes or wash or shave. All of those could be just because you are so depressed and down, you don't feel like doing anything. But his mocha is 22 out of 30, which again, if he's not making a good effort on mocha on the examination, you could get a 22 out of 30 because of poor effort, not because that patient has an actual underlying deficit. Now, Alzheimer's dementia, is likely where this could have gone if presented a little differently. 22 out of 30 is actually pretty good performance for an early Alzheimer's. So that will again be a little challenging. Normally, early Alzheimer's have a good mocha. They typically have mocha around 25, 26 because MMSE is the one that drops first. So in MMSE, they may be 22, but on mocha, uh, on MMSE, they may be around, actually, sorry, the opposite way. So MMSE, they may be around 26 or 27, but on mocha, they're 22. But then that is still considered MCI because the diagnosis usually in Alzheimer's is dependent on MMSE, which was designed for Alzheimer's disease, while mocha is not that reflective of the challenges of Alzheimer's disease. But, except for this curveball of forgetting his family members and suddenly remembering something and then being like his old self, which may be unrelated information. And in real life that happens. Although, as I mentioned, in STEM, in a question, we try not to reflect the real life that accurately, because then it becomes very confusing for someone to pick the answer. Frontotemporal dementias is unlikely here. There is no executive dysfunction, and there is no behavioral outbursts or things like that. Normal aging is unlikely. Mocha should not be 22 out of 30 just because he's 76. There is some decline, but usually these scales are tested in older people, and they are not very sensitive to aging. So there's something real has happening, although forgetting one payment may not be unusual, but more than one will be unusual. Let's see what the question writers picked up as the answer. Alzheimer's dementia. So as I thought that they were trying to go for Alzheimer's and most of the things fit, actually in real life, all of this could fit in real life. The family could say that they sometimes forget family members, and or they basically saying, oh, they cannot remember the name, although recognize the person, they just cannot get the name out. Or they will say suddenly he's better than old self. But in STEM, we typically try not to put this kind of information, which could confuse someone trying to answer the question. All right, let me stop here and we'll do another question later.